PhD Fellow at Roswell Park Cancer Center. It's my pleasure to introduce Dr. Hashmi. Dr. Hashmi completed his MBBS at King Edward Medical University, followed by internal medicine residency at Michigan State University. He then pursued Hematology Oncology Fellowship at University of Weill, followed by advanced training of bone marrow and transplant and cellular immunotherapy at Lee Moffitt Cancer Center and Research Institute. He is currently an assistant professor at Memorial Sloan Kettering Cancer Center, where his research focuses on novel therapies for multiple myeloma, with a particular emphasis on CAR T cell therapy and optimizing real-world patient outcomes. Please join me in welcoming Dr. Hashmi.
Thank you for the kind introduction and having me here today. Can you all see my slides?
Yes, we can see your slides.
So good morning and good evening for those who are actually joining from Pakistan. I'm Hamza Hashmi. I am a physician at Memorial Sloan Kettering in New York City. In my practice and my research, I focus on plasma cell disorders, including multiple myeloma and amyloidosis. And today, my goal is not to have you become a specialist in amyloidosis, but actually give you a very good understanding of the basics of the diagnostic workup and some of the important clinical pearls and principles of management of patients with AL amyloidosis. Specifically, how we diagnose AL amyloidosis or how we try not to miss the diagnosis of amyloidosis, how we treat or not treat amyloidosis. When it comes to amyloidosis, what is old and outdated as treatment? What is old and gold? What are the new standards of care and emerging therapies? And finally, does transplant still have a role in AL amyloidosis in resourceful as well as resource limited settings? So amyloidosis is a form of disorder where an abnormal protein gets deposited in extracellular body tissue, disrupts the structure of that organ, leads to organ injury and eventually organ failure. All amyloid proteins are essentially normal protein that undergo an abnormal configuration, become an antiparallel beta-plated sheets, oligomerize, and then get deposited in the body organs. There are at least 30 different kind of proteins that can be involved. They can be seen in 7 different kinds of disorders, but the 4 most common ones that we see in our practice are mentioned here. And I will start off with some of the more common ones, including the transthyretin amyloid protein, which can be age-related or senile, as we call it. We also call it ATTR amyloid. And you typically see that happen in elderly individuals who are 70 or above. They can present with cardiomyopathy or soft tissue deposits of amyloid. Anytime you see an ATTR amyloid, it's important to make sure that you rule out any genetic mutations that can be seen in familial forms of transthyretin amyloidosis. It's a very simple test. It's a serum or a saliva test for the mutations. And if the patients tend to have that mutation, they do qualify for certain therapies for cardiac amyloidosis that can help improve outcomes significantly. Usually these patients with familiar or mutated transthyretin amyloidosis are managed by cardiologists. Again, familial transthyretin or ATTR amyloidosis, it inherited an autosomal dominant pattern, tends to run in families, more so African Americans. And if you see young patients with those symptoms, make sure that you test for the mutations in these patients. AA amyloidosis, or also we used to call it secondary amyloidosis, is typically seen in patients who have chronic inflammation, either in an autoimmune condition or for that matter, an infectious condition. Common autoimmune conditions that you may see this would be rheumatoid arthritis, inflammatory bowel disease, chronic infections that you may see this will include osteomyelitis, bronchiectasis, tuberculosis. In my entire practice, I've only seen two patients till date with AA amyloidosis, and this was again a diagnosis made on mass spectrometry. Uh, Typically tend to affect the kidneys. And that particular patient actually had inflammatory bowel disease, uncontrolled ulcerative colitis, worsening renal function, and biopsy showed amyloid, and mass spec showed AA renal involvement for that particular patient. So you treat the underlying condition, the inflammatory or infectious condition in those patients. It's important to remember that for tuberculosis because you can see those patients develop amyloid. And then last but not the least, AL amyloid, which is the main focus today, where essentially what you see are malignant plasma cells or B cells sometimes that make light chains that undergo structural configuration, oligomerize, become insoluble in blood, circulate in blood, and get deposited in organ tissue and cause all the damage. It's an uncommon disorder where you can see this co-occur with myeloma in about 10 to 15% of all patients with myeloma who have or meet the criteria for the CRAB can have amyloid. Usually patients with myeloma who have a myeloma features with high light chains, high disease burden, bone marrow involvement, lytic lesions, they tend to behave like myeloma, even when they have amyloid involvement, which means that you can treat them with 4-drug induction regimen, transplant, Len maintenance. In fact, I have had patients with myeloma as well as amyloid, and I've treated them with CAR-T, seen very effective responses without having any excessive toxicities. So it's important to remember that they tend to behave more like a myeloma phenotype. It's a rare disorder. For every 20 patients with myeloma that I see one patient with amyloid. Uh, the prevalence is somewhere around 10 cases per million people, but it's not an uncommon disorder and can affect um, uh, celebrities as well. Here you see a very famous Pakistani um, personality in the political history who actually succumbed to AL amyloid with renal failure and advanced stage liver involvement. The organs that tend to be affected most commonly include heart and kidneys. 60 to 70% of the times you will see those organs affected at the time of their presentation. You can also see gastrointestinal involvement, about 20% of the individuals, usually involvement of the esophageal tract, stomach, small bowels. And then you can see nervous system involvement as well. And we like to distinguish the peripheral nervous system involvement for the autonomic nervous system involvement. Isolated peripheral nervous system involvement in the form of neuropathy with no other signs of amyloid is very rare. It's actually only 10% of all cases. So if you ever see neuropathy as the only feature in your practice, it's unlikely to be amyloid if other organs like heart and kidneys are not involved for those patients. I've seen patients who have had soft tissue deposits of amyloid as well, including lymph nodes, liver, as well as skin, where what you see are nodules and plaques that look like if they have an autoimmune skin condition, but when you biopsy them, you see amyloid. Many times we actually just watch these patients with skin and soft tissue involvement. TTR amyloid, especially when it's senile, when it's age-related in elderly individuals, they can have those soft tissue deposits. This slide is going to be very important because here I will talk about the typical and the atypical presentation of amyloid and how it affects the organ function and presents in those particular individuals. So again, kidneys can be involved in nearly 70% of the individuals and tend to cause nephrotic syndrome. Essentially means that a patient will present with fluid retention in their feet, ascites, pleural effusions. You check a CMP, you'll see a very low albumin. Your next best step is, if you're a patient in the clinic, you do a UA, you see 3 positive protein urea. A 24-hour urine with UPEP immunofixation should be done for that particular patient. And you will see for that particular patient, they will have tons and tons of protein urea in the urine. And the immunofixation will show you that by and large, all of that is actually albumin and not a monoclonal protein. Reason being that the light chains in amyloidosis, they affect the kidney tubules and they tend to spare the glomeruli. Oftentimes in these patients with nephrotic range proteinuria with renal amyloidosis, creatinine and GFR is preserved. 60% of the patients at a time of their presentation will actually have cardiomyopathy. It tends to be a restrictive or infiltrative cardiomyopathy, where they present with symptoms of congestive heart failure with a preserved ejection fraction, shortness of breath, fluid retentional, exertional dyspnea. They don't usually get chest pains that we see with ischemia. If you do an EKG with advanced stages, you will see that they have low QRS complexes, but it's a very non-specific finding. Echocardiogram, when done, if you have a high clinical suspicion and you have an expert sonogram reading person, they can actually see thickening of the septal wall and the ventricular wall in these patients. It's very important to highlight and when you place an order, they're suspecting amyloidosis and they can pay attention to the thickness of the walls. In very severe cases, you may even see a speckling pattern. I think it's more for the books and the boards rather than in clinical practice that we see the speckling pattern. And then finally, cardiac MRI is one of the most sensitive test for cardiac amyloidosis with delayed gadolinium enhancement. In cases where I actually am not able to obtain heart biopsy, I find cardiac MRI to be very helpful for infiltrative cardiomyopathy and amyloidosis concerns. Important thing to remember, these patients do tend to have involvement of the nodal system, conduction system, which means SA node and AV node can be affected. Very common to see arrhythmias, atrial fibrillation in these patients. When the AV node is involved, they can actually have ventricular fibrillation and ventricular fibrillation arrest. One of the most common causes of death, oftentimes in these patients, actually sudden cardiac death. And it's very important to send these patients to cardiologists if there is endomyocardial involvement, have electrophysiology assessment done, and make sure that if they need a pacemaker, we actually put that in these patients to prevent mortality. So important to remember heart failure with preserved ejection fraction, and then the conduction abnormalities that you tend to see these patients. You rarely tend to see coronary artery disease unless the patient has other risk factors. That is very advanced stage where the amyloid can get deposited in the coronaries. Having said that, almost every one of these patients will have an elevated troponin in the serum. Reason is that when we have infiltration of the myocardium, it releases the troponin, and even a small amount of involvement can release the troponin. That will raise concerns for stamina and stamina in patients, but your angiography would usually be normal in these particular patients. You can see the liver involvement typically shows up on the scans as a very enlarged liver in more advanced patients, but what you see on a CMP, a metabolic panel, is actually elevated alkaline phosphatase in these patients. So if I see elevated alkaline phosphatase and I think of liver involvement, I always in these patients check for their coagulation factors. I look for factor 10. I look for the PT, PDT, INR, because if the liver is involved, they will have those factors being deficient. And any biopsy that you may plan, like a kidney biopsy, like a heart biopsy, it may be associated with risk of significant bleeding. So that's a very simple clinical pearl that if ALK phos is high, look for liver involvement, check for coagulation factors, and be careful with any invasive procedures. The neuropathy that you see in these patients is very, very characteristic of what we call small fiber neuropathy. So what is small fiber neuropathy? Small fiber neuropathy means the neuropathy that affects the nerves in skin and in distal extremities. Typically, the patients have symptoms of tingling and numbness, and that's usually associated with painful burning. You don't see painful burning sensations with neuropathy that you have in early stage diabetes or neuropathy that you typically see with bortezomib and other chemotherapy. So if the neuropathy is in the distal extremities, more so the feet and the fingertips, if it's symmetric on both sides, and if it's tingling, numbness, and painful burning, that tends to be what we see with AL amyloid. Small fiber neuropathy. So if you do nerve conduction testing, it's not going to show you any significant findings. So some important points to remember when you see these features of neuropathy in these patients. That's peripheral nervous system involvement. When you look at autonomic involvement, what you typically end up seeing is orthostatic hypotension. The patient stands up from a sitting position and they become dizzy and lightheaded and they can have a fall. That's orthostatic hypotension, simply by the virtue of the blood vessels that are supplying innervation or they're supplying blood to the nerves are affected by the amyloid deposits, and a patient is unable to compensate for with increase in the heart rate as they stand up from a sitting position. You can notice also bladder and bowel emptying function, problems with autonomic dysfunction, and it can be seen in about 15% of all of these individuals. But orthostatic hypotension tends to be a major problem in these patients with neuropathy. Macroglossia is more for the, again, books and the boards. You can ask the patient to stick out their tongue, and what you will see is that because of amyloid deposits in the muscle of the tongue becomes big. When it becomes big, your teeth are actually biting on the tongue as you are in sleep, and you can see those bite marks appear there. What also you will notice is that these patients have a muffled voice. They almost always have snoring at nighttime because the tongue fills up the mouth and it can fall back. And you can notice some of these voice changes in these particular individuals. Carpal tunnel syndrome, very important point to remember. It's on the boards and books, they always test it. But anytime you seek history on carpal tunnel syndrome, it's very important to remember this. The most common cause of carpal tunnel syndrome is overuse of your hands and the way you move your wrists. So the fascia can become thick, it can compress on the nerve, and you can notice carpal tunnel feature. If carpal tunnel syndrome or features of tingling and numbness is mostly sensory, is seen on a non-dominant hand, for in my case, I'm right-handed. So if my left hand is having features, or if I'm having features in both hands, think of AL amyloid, think of hypothyroidism, think of acromegaly. Acromegaly is very, very easy to see on exam, but amyloid is important. So what I've done in some of my patients is that if they ever go for carpal tunnel release, I tell the surgeon to get a piece of the tissue and I run the stain for the Congo red on that piece of the fascia, and it actually shows amyloid. And then periorbital edema, again, purpura, you've seen raccoon eyes. Simply what it happens is because the blood vessels in that area around the eyes, they become fragile with amyloid deposits. If you cough, if you sneeze, if you do a vulsa-vulva maneuver, because of that pressure, the positive pressure, the eyes, the blood vessels can rupture. The skin is already delicate, and you notice those raccoon eyes. Again, I don't remember the last time I saw any periorbital erythema in these patients. But again, exam finding that you can notice. How do we make a diagnosis? We make a diagnosis by the best way of making a diagnosis is actually diagnosing or biopsying the organ that is involved, which can be the kidneys, the heart, sometimes the nerves, and then running the test for the amyloid protein, as well as looking at that subtype of the amyloid protein, whether it's ATTR, AA, or AL. Here you can see again some macroglossia, you can see nail dystrophy, you can see the changes on the echocardiogram that are known here. This slide is more important. Here you can see the Congo red stain. Essentially, you take the sample, the biopsy sample, you throw some Congo red on it, and you run a polarized light on it. And if you see apple green birefringence on the polarized light examination, this is characteristic of amyloid deposit. But it doesn't tell you anything where it's coming from, whether it's ATTR, AA, or AL. That requires us to actually run some more testing. For patients who have kidney involvement, you will see amorphous deposits, yellow appearing or pink appearing deposits on the kidney biopsy. They're amyloid, but you can also throw some immunohistochemical stains on it. And those stains will be picked up for kappa or lambda, and you can make a diagnosis sometimes without even requiring mass spectrometry or laser microdissection. It's a specialized test. All of these tests go to Mayo Clinic in US. It may not be available at all sites. So it's important to know how to make a diagnosis in case you don't have access to mass spec or laser microdissection. In US, it's the gold standard, but in other countries, it may not be available. So for kidney biopsies, it can be Congo red stain and immunohistochemical analysis, which all biopsies do. And you can know whether it's kappa or lambda restricted along with amyloid deposits. And this is again a slide you can see how the mass spec is done and how it shows you which particular protein is involved. I do want to share one pearl here, and just because I'm giving a lecture to a national audience, in case you don't have access to laser microdissection or mass spectrometry, the only time that I think it becomes important to run that test that you should be doing it to make sure what particular type of amyloid you are dealing in is someone who is age 70 or above. They have cardiomyopathy, they have soft tissue deposits, and you think this could be senile or age-related cardiac amyloid. Secondly, in US, we have African American individuals, they have family history of cardiomyopathy, sudden cardiac death. If they come with cardiac amyloidosis and neuropathy symptoms, I think of familial or mutated, as they call it, TTR amyloidosis. So I run saliva and serum test on those patients for the mutations. And finally, if you have a patient who has a chronic hepatitis going on, NASH going on, they may have a AA form or apolectins form of amyloid and not just AL amyloid. I fully understand the limitations that some resource-limited countries may have when it comes to laser microdissection. And hence these can be helpful. Moving on to how we make a diagnosis, let's say you suspect amyloidosis, you will run a serum protein electrophoresis, urine protein electrophoresis, and serum free light chains. If any one of the three come back positive, you should look for amyloid. You should look for amyloid, and easy way of doing this is that you do a bone marrow biopsy and a fat pad biopsy both at the same time. And if they come back positive, you have made a diagnosis of AL amyloid. But if they are negative and your clinical suspicion is very high for heart or kidney involvement, especially, then you should go after that organ. You should biopsy that organ, the heart or the kidney, and determine the subtype of the protein as well. Let's say the bone marrow and fat pad is positive, then you want to make sure that there is only localized amyloid, which means that if your bone marrow is positive, but you don't have heart involvement, you don't have kidney involvement, you don't have significant nerve involvement, you don't always need to treat these patients. You can always watch them as well with serial labs and things like that. Similarly, for localized AL amyloid, which tends to involve the tracheobronchial tree, the voice box, the trachea, the lung, and the bladder, you don't need to do anything if they're not symptomatic. If they are symptomatic, you can send them to a surgeon, radiologist, radiation oncologist, and they can radiate it, cut it, resect it. Very rarely you will ever see that a localized AL amyloid becomes systemic. When I see these patients for localized AL amyloid, I run a comprehensive testing, make sure there's no other organ is involved. But after that, I don't treat them, and I usually only follow them once a year with blood work and things like that, because it's very rare to see systemic involvement once you ruled it out. Other important thing to remember here, if your SPEP, light chains, or UPEP is negative, it's highly unlikely that you actually have a case of light chain amyloidosis. Only 2% of all AL amyloidosis is negative in all these three tests. So if it's negative, I usually don't think of other possibilities. Here is a list of all the tests that we run for these patients. I'm going to quickly walk you through those. CBC oftentimes is going to be normal. You may not see any abnormalities on CBC. SPEP will show you likely will show you, can show you a heavy protein with a lambda subtype. Free light chains are very important. That is what we use for response assessment as well. 24-hour urine will tell you how much protein is being spilled. Remember, it's heavy protein urea, mostly albumin, and very little to none light chain seen in the immunofixation. Similarly, coagulation profile is important, especially if your alkaline phosphatase is elevated on the CMP. Troponin T, if you have a trace amount of amyloid in your heart, if you have a little bit of speckling and involvement, your troponin will leak. Your troponin will be high. I have patients with cardiac amyloid come in and get this testing done, and every single time I get a call from my lab that troponin is high, they're having ischemia, they're having heart attack. No, is because of the amyloid in the heart that you're seeing a leak of the troponin. NT-proBNP has value in staging. It has value in response assessment as well. We evaluate at least at diagnosis for everyone. Afterwards, I usually follow them with PNP because it's cheaper, it's easier, it comes back faster as well. But remember these two tests that you can do for these patients. Factor 10, always do it for concerns for hepatic or liver involvement, because if liver is involved and the factor 10 levels are deficient because they're consumed by, where they're absorbed by the light chains, you get high risk of bleeding. We usually replace these factors in patients who are going through invasive procedures, or for that matter, importantly, if they're having active bleeding. Skeletal survey, more to rule out lesions. If there's myeloma in there, EKG, we do that. Echo, we try to do for all patients to see if they have any pattern on strains and the interventricular septum as well as the ventricular wall. And MRI is the most sensitive test. If you can't do a heart biopsy, you have elevated troponin, your cardiac MRI is a very good test to actually look into cardiac amyloidosis. Some people do PYP scan. I want to say a few things about PYP scan. PYP scan in a patient with AL amyloid is either going to be normal or is going to be borderline or intermediate. PYP scan has its maximum value, best value, or bang for the buck when it's actually ATTR amyloid. So if your cardiologist sees the patient, they will do PYP scan for all of the patient. It doesn't mean anything for me when it comes to, but if they do a PYP scan, it's negative, they'll say they don't have AL amyloid. That's incorrect, completely incorrect. So I've have multiple cases where PYP scan is negative, and then cardiologists would actually not think of amyloid as a differential. Nerve conduction testing going to be normal. It's a small fiber neuropathy. Just remember that. And then endoscopy for patients who have gastrointestinal involvement. Typically, they will have anorexia. They will have esophageal motility problems. They will have pain and dysphagia when they swallow. They will have delayed gastric emptying. One of the classical symptom of GI amyloid is delayed gastric emptying. Early satiety, um, uh, uh, feeling of alternation of diarrhea and constipation, and then bloating. If you notice that in an amyloid patient, they very likely have AL amyloid. Sometimes I try to prove that or rule out any masses that maybe they're in the bowels by doing an endoscopy and blind biopsies. If you send the patient to GI, they're doing an endoscopy or a colonoscopy, especially like a sigmoidoscope, like a flexible flexic. Tell them to do random biopsies. Amyloid is not going to show up as a mass on your endoscopy. It's subepithelial, so they have to do random bites, random biopsies of the bowel, and they will find it actually on the congruent staining. So it's very important to remind your GI friend that please do random biopsies on these patients and not just if you see a mass. Um, and this is perhaps one of the most important slides. What are the warning signs? When should you be testing for amyloid? Again, testing is simple. SPEP, UPEP, light chain. Simple test anyone can order. Anytime you have a patient who has nephrotic range proteinuria and they're not diabetic, look for amyloid. Anytime you have a patient who have symptoms of HFpEF, as we call it, heart failure, with preserved ejection fraction, they have clear symptoms and they don't have any risk factors for ischemia. You do a angiography, heart cath, and you don't see any blockages there, and they still have HFpEF. Look for SPEP light chains and UPEP. If you have a patient who, again, they may have elevated alkaline phosphatase, they may have a big liver on their imaging, look for these. But oftentimes, when they have GI involvement with the liver, especially, they have other involvement as well. Other organs are already involved by that time. Peripheral neuropathy, very important to remember. I think for my neurology friends, if you have a patient who comes in with sensory motor peripheral neuropathy, uh, that you have treated with high dose IVIG and steroids and hasn't gotten better, in fact, got worse with it, look for AL amyloid. But important to remember that in diabetes, the diabetic neuropathy, when you see it, is a glove stocking neuropathy, which means that it's a small fiber. But what you typically notice is that they have issues with tingling uh, and numbness and a sensation of cold or heaviness in their feet and fingertips. It happens in late stages or medium intermediate stages of diabetes. What you notice with amyloid is pain, tingling, numbness, and burning pain, as if someone has put like your fingertips and your feet especially on fire. That is a small fiber neuropathy that should raise concerns for amyloid. So if you see a patient who has controlled diabetes or not done no diabetes and they have neuropathy like this, tingling, numbness, burning pain, look for all of these three lab abnormalities. And again, patients with MGUS, that's very important for anyone here is a hematologist or an oncologist. If you're seeing MGUS patients in your clinic and a patient comes in and they have atypical features, for no good reason, they are losing their weight, they're profoundly fatigued, you're seeing fluid retention in their feet uh, as an ascites, and you can't figure out that why this patient is so profoundly fatigued and tired and losing weight with anorexia. Look for amyloid, especially if they have to have a lambda subtype protein in their SPAP and light chains. Run a bone marrow biopsy, do a fat pad biopsy at the same time for these patients. Typing is very important. Amyloid typing is important. The way we do typing, because you can find a congruent stain will pick your amyloid in the heart, in the kidneys, on the skin, fat pad, bone marrow. But you need to determine what particular subtype it is. And the way we do that is laser microdissection or mass spectrometry. In US, it goes to Mayo Clinic. If you don't have it available in the kidney sample, you can always do immunohistochemical stains, and that can help you make diagnosis. But and situations where you again you want to make sure this is not an ATTR or some other form of amyloid that you should not be treating with chemotherapy is if someone is elderly and they have cardiomyopathy with skin deposits, In US, I pay special attention to African American individuals who have cardiomyopathy, family history, young age. Actually had a patient who had both TTR and AL amyloidosis at the same time, and I was able to find it through saliva and serum testing. Those would be the patient, especially again, if you have someone with hepatitis infection and NASH, they can sometimes have more of an inflammatory related amyloid rather than AL that needs chemo. Important to remember those. Localized amyloid, again, remember, it's very simple. They always, almost always, you'll end up seeing them in the airways, like a trachea, larynx, sometimes in the lungs, and then in the bladder. You don't do anything for it. You make sure there's nothing, no bone marrow involvement, no kidney involvement, no heart involvement. If you even have deposits on your CT scans in the lungs, you can just watch them. The body will take care of it. It's usually chronic inflammation for smokers, and then for people who have chronic cystitis, they will have inflammation related localized AL amyloid. You can resect it, you can cut it, you can radiate it, and you can just watch it as well sometimes. But it's not as ominous a condition as systemic AL amyloid. And again, if your SPEP, UPEP light chains are negative, there is 2% chance that still they have AL amyloid. So, in other words, highly unlikely this is going to be AL amyloid. And in those patients, you should look for alternate causes. Let's move into the treatment section here. I have half an hour, and I think I should be able to cover this in the next half an hour. In patients with AL amyloidosis, the source, the factory, the origin of the uh, uh, abnormal light chain is the bone marrow. And again, if it's a lymphoma, Waldenstrom, it's going to be the lymph node area. But bone marrow is the factory, it's a source, and we shut it down. How we do that? We give chemotherapy. We can give chemotherapy as traditional chemotherapy. We can do transplant. We essentially eliminate the plasma cells in the bone marrow that are making the light chains. So that once the plasma cells are gone, no more additional light chains are made. Having said that, whatever abnormal amyloid light chains have been made, and more importantly, deposited in the organ, you cannot get rid of that with chemotherapy. The body will, the macrophages will, they will digest it, they will absorb them, but they usually take 2 to 3 years after starting therapy to be partially or completely eliminated. The reason I say this is because I start patients on chemotherapy. I see the light chains disappear right away. I see the bone marrow get cleaned up with the plasma cells, and patient's organ function either declines or doesn't improve. And I reassure my patients that it can take up to 2 to 3 years after starting your therapy, or even sometimes finishing it, that your kidneys and your heart will recover. So reassurance and education is very important for those patients, and management of those heart on organ failure symptoms is very important. Historically, 30 years ago, we used melphalan, prednisone, and melphalan steroids for these patients. Oral melphalan in this particular case is still available, again, in resource-limited settings, works in about 25% of the patients, usually patients who come to their disease in about 12 months or so. If they happen to have cardiac involvement, they usually die within six months time. But again, it's used historically, not anymore in US. I rarely see a patient with oral melphalan steroids getting treatment. CyBO-D has been used over the last couple of decades, I would say, for patients with AL amyloid. It can be effective form of therapy. I would say nearly 2/3 of the patients would have some sort of a response, although the complete remission, complete response, the light chains are all disappeared, or only about 20% of them. You will see some heart and renal responses as well, but again, in 20-25% of all patients. Remember, whenever you give CyBO-D to patients, please give bortezomib only once a week. In my practice, I actually gave it in a 4-week cycle. I gave it 3 out of 4 weeks. You can start off with a dose of 1.3 milligram per square, but drop it if they have baseline peripheral neuropathy or if they develop it. Usually, you don't see someone develop peripheral neuropathy with once weekly bortezomib, but these patients are predisposed towards neuropathy. So if you see, drop the dose quickly with the bortezomib in these particular patients. Cytoxin is tolerated well in these patients usually. Transplant has had a role. It's been evaluated over the last 2 decades, and this is again a study from late 1990s, early 2000s, where they show that patients who undergo transplant and achieve a complete remission can actually have long-term survival. Having said that, the best outcomes are seen when you go to a transplant and you achieve a complete remission and you don't have cardiac involvement. So these are very important factors to remember. that it's not just transplant, but actually not having cardiac involvement and achieving complete response that actually improves outcomes in these patients. This is an experience shared by Mayo Clinic for about nearly 1,000 patients that they had with AL amyloid. And what they noticed in their 10-year experience is that patients who, when they present, don't have advanced stage cardiac involvement, are able to go through transplant, are able to achieve complete remission after transplant, are the long-term survivor. In other words, early diagnosis is key so that you don't have as advanced stage heart involvement at that time, and you have better eligibility to go through transplant and achieve deeper remissions and long-term survival. Which brings me to the transplant eligibility. Um, I think the role of transplant in US is evolving because we have such effective therapies available nowadays, but it still is a very relevant treatment options in resource limited settings. 2 years of data VCD based therapy may actually be more expensive than high dose chemotherapy, autologous transplant. So it says has its value, but its eligibility has to be very carefully assessed. Usually anyone who is above the age of 70 and have borderline performance status, we tend not to consider them uh, transplant eligible. Patients should have creatinine clearance above 30 or a stable renal dysfunction. It becomes harder to do this when they are on dialysis, especially when we have to collect stem cells. Not that it can't be done, but severe organ involvement with AL amyloidosis can actually be problematic for transplant eligibility. And finally, heart failure. I mean, in my practice, I think heart failure symptoms are the key when I assess these patients. That if someone has NYHA, New York Heart Classification, class 3 or 4, which means, but then they walk, they get short of breath within a certain distance, they're wheelchair bound, I don't do transplant. It's more important for me to look at clinical heart failure symptoms than actually look at the cutoffs with NT-proBNP or troponin for these patients. Similarly, if the patients have multiple organ involvement or severe involvement of the heart or the kidneys, they can be barrier towards transplant. In US, despite meeting a lot of this eligibility, we are doing fewer transplants, in my opinion, because we have such good therapies available nowadays. But again, in a source limited setting, make sure that the patients of adequate performance status, they have adequate renal function, and they should not have advanced stage heart failure symptoms. Because when you try to do transplant for these patients, a lot of fluid shifts, hemodynamic instability, cytokine release, and these patients can easily tip over into advanced stage failure of the heart or the kidneys. And then, in fact, we can even experience mortalities. This is what we noticed when we started doing transplant in US in the late 90s, early 2000s. Our mortality rates were as high as 20-25%. Over a period of time, we got better with patient selection. And we started doing it transplant in a safer way as well, where the mortality rates actually come down significantly nowadays, less than 5%, even in big centers. Moving on to Andromeda trial, this was a study that was done in US and Europe. It actually eventually led to the adoption of data VCD as the new standard of care in US. Everyone in this country gets data VCD. I rarely see anyone just do VCD anymore because data is widely available in US, and it actually makes a huge impact on outcomes. Because when you compare data VCD with VCD alone, you not only see deeper hematologic remissions, but you in fact see better organ recovery and less organ failures in these patients. Usually when you start someone on data VCD, within 2 months time, you end up seeing very good partial responses. I have seen complete remissions within one cycle sometimes. And deeper responses, faster responses is the reason why you are seeing organ recovery and improvement in survival outcomes in these patients. So data VCD is what we do in US. And our ability to achieve deeper responses has actually really brought the role of transplant into question here. If someone is able to achieve complete remission after 2 cycles of data VCD and they complete 4 more cycles of it and they're already in a CR, do they really need transplant? Or can we just give them additional daratumumab and collect and store their stem cell, maybe do transplant later if they ever have a relapse? So that's an observation that we all have shared, and we believe that we can spare our patients the rigors of a transplant by just giving them effective upfront therapy. But also, what we have noticed is that many patients, when they get effective therapies like dara-VCD, it does give them deep responses, early responses, does improve their organ function. It makes them more eligible towards a transplant. So someone who was not eligible for transplant to begin with will become eligible because they have heme response, organ response, performance status improvement. So there's a trial that is actually ongoing that's looking at um, transplant versus chemo uh, uh, for patients with AL amyloidosis. I think there will be some issues with enrollment as well because the practice patterns in US are, I think, evolving, that we are collecting and storing for a future transplant, but we're not transplanting all our patients because we see such good deep responses with data UBCD alone. So how do we treat for a transplant eligible patient population? I borrowed this from your clinic. They are a great site for myeloma and amyloid. They have all these guidelines, and I can walk you through these. And I think they're very appropriate, very relevant in this particular circumstance. So if you have a transplant eligible patient with AL amyloid, we usually give dara VCD as a starting therapy. They should achieve partial response by 2 cycles or a very good partial response by 4 to 6 cycles. If a patient is unable to achieve a partial response at the end of their therapy, uh, especially 4 cycles, and in fact, even 2 cycles, they're not really responding very well. We like to change those therapies because early responses mean organ recovery, and that improves outcomes. So we like to escalate therapy if the patients are actually not achieving deep hematologic remissions early on in these with dara VCD. So for patients who achieve adequate response, we collect stem cells. If they achieve a CR, actually, I don't do transplants anymore for those. I collect and store stem cells, but for CR, complete remissions, I don't. For patients who do not achieve a CR and the best response is perhaps very good partial remission, I discuss transplants. And if they're eligible, they're interested, they're candidates, transplant remains an option for those patients. Anytime we don't do transplant and patients have in fact achieved a complete remission, I discuss with my patients whether they want to continue single agent data or if they just want to undergo observation. I don't have data to show you or convince you, but I do think for someone who achieves complete remission after 6 cycles of dara VCD, whether they really need additional 18 months of daratumumab or they can just be observed, needs to be determined in trials and may not be an irrational strategy for those particular patients. And again, if patients are not able to achieve hematologic remission, we try to treat them with an alternate therapy. Transplant ineligible dara VCD. For every one of those patients, we do dara VCD. And again, at the end of 6 months, if CR observation is appropriate, unless they really want to give 18 additional months of data. And if they have not achieved a CR, only a VGPR, I do offer them 18 more months of dara VCD at that time. For relapse refractory AL amyloidosis, there are multiple different options available in the form of immunomodulatory agents, proteasome inhibitors, alkylating agents. I've put in some response rates from historical data here. I do want to throw some caution here that lenalidomide, you should never use more than 10 milligram. If they have advanced stage heart or renal involvement, I don't use it because it can make that organ function worse. You can use bortezomib, but it can cause neuropathy, so adjust the dose. If you want to use an proteasome inhibitor, Nilaro or ixazomib is an option for those patients. The responses are not as robust. Pomalidomide, and never cross 2 milligram. I only usually give them 1 to 2 milligram of it. And then bendamustine is something that we consider for more Waldenstrom or lymphoma-like patients. Having said all of that, what we have really started using more and more in our practice is actually venetoclax, especially for 11-14 translocated AL amyloidosis, which is 50% of all AL amyloid. So it's very important to run the test at the time of their diagnosis. 50% will have them. And at the time of their relapse, I actually go to venetoclax. I use a flat dose of 400 milligram. I use it daily. I don't do a ramp up. You don't need it. I add some dex with the venetoclax, small doses, and it works better than any other therapy for these light chain AL amyloidosis than we have seen. It does get some pretty deep and early remissions, and they can last for some time as well. US, we have used bispecific antibodies at some institutions. We have found very deep responses without having any excessive toxicities. And I think bispecifics are being investigated in trials for AL amyloid and may actually even have an approval in the coming years based on how effective they can be. And I think it also opens up the opportunity for time-limited treatment of bispecific. 6 months of bispecific, eliminate the clone, and have not be able to do, not wanting to do, no need to do transplant at the same time. With 6 months of treatment, you are actually able to achieve deep and durable remissions. And finally, CAR T cell therapy is being investigated. MSK is a leading site in the country right now for CAR T trials. Very deep MRD negative remissions we have seen within a month's time without any excessive heart or renal toxicities. And I think this may actually also lead to an approval in the coming years or so. Amyloid-directed therapy has been investigated in US and I would say in Europe as well, where, as I explained to you, that light chains can be eliminated by chemotherapy and transplant. But whatever is deposited in your organ may not be, is not going to be eliminated, and it needs more time to actually be digested by the immune cells in the body. What amyloid-directed therapy does, it has binds to those light chains that are already attached to the organs, digest them, degrade them, and help in organ improvement. For one reason or the others, a lot of these trials, three of them mentioned here, actually did not lead to an FDA approval because they failed to meet their primary endpoint or could not enroll enough patients. I think patient selection criteria, very ambitious primary endpoint in these particular trials, were some of the reasons why we were not able to see a success that would lead to an FDA approval. But they are being investigated, and hopefully one day one of these products will be available as well that can improve outcomes, especially in advanced stage organ failure patients. As of now, they're not available as standard of care. Finally, in the last few minutes or so, I think I will try to walk you through some of the supportive care measures in patients with AL amyloid. They're very important. You may not be at a site where you have access to a cardiologist, a nephrologist, a neurologist. I work with all of them, uh, being at a large academic center. But there are still some skills, the clinical skills that you can learn, that you can apply, that you can actually take upon your own in your own practice and help with your patients with. And I'm going to share some of those here with you. That fluid retention is very common, especially with cardiomyopathy patients, which is 60 to 70% of all new AL amyloid. Salt restriction is important. Diuretics is what we need. We need to make sure that these patients are being diuresed in an appropriate rate. When you do that, you have to make sure that if they have orthostatic hypotension, you're not completely running them dry with the diuretics. But diuretics are the mainstay for the fluid retention in these patients. Orthostatic hypotension is actually common in late stage amyloid, and it can be a big challenge in management of these patients because the moment the patient stands up, their heart rate, their blood pressure drops, and the heart rate does not compensate for it. Anytime they walk into your clinic and your nurse checks the blood pressure, it's like 60 by 40. And a patient is sitting there and looking at you. And for these patients, we do midodrine very commonly. 3 times a day midodrine is something that we do to help them with some of the orthostatic hypotension, some of the symptoms. I have actually even used this medicine called droxidopa in some of my patients, and I've seen some improvement with it. It does require you to have them see a cardiologist. But otherwise, remember, midodrine 3 times a day is something that can help with orthostatic hypotension. Compression stockings are very important, and behavioral modification, how to sit, how to stand, how to walk, is very important for these patients to learn some of these basic management measures. Neuropathy, again, it's a small fiber neuropathy. It's a painful burning neuropathy. Gabapentin is helpful for those patients. You can try those. Sometimes there are some creams that you can apply that can help with these symptoms. If they have baseline neuropathy, be very careful with bortezomib. I actually start at only 1.0, not 1.3 milligram per square, and I actually try to control the disease because that's what's causing neuropathy. So I don't completely eliminate it, but I reduce the dose and the frequency in these patients. If you have GI symptoms, which means that you have anorexia, nausea, early satiety, diarrhea, it's important to know that if there is amyloid in there, but that will not affect your management. You will still manage them symptomatically. You will still give them medicine for diarrhea and constipation, um, and try those things to help those patients. Uh, Renal failure, again, because of the nephrotic range proteinuria, can be seen. The way we do renal staging is based on their GFR and their proteinuria. So I actually always check it at the time of diagnosis, and I usually check it every 3 to 4 months time when I'm giving them treatment to see if it's improving or not. Uh, there is a chance that these patients can actually eventually end up on dialysis, and they remain on dialysis for the remaining years. There have been times that we have actually looked into doing renal transplant for these patients. If you ever consider anything like a renal or cardiac transplant, in big centers in the US, they do it. They require us, hematologists, to completely eliminate and eradicate the AL amyloid before they would take the patients for a kidney and a heart transplant. So it's important to make sure that we have therapies that you can kill everything with before they would be considered for those transplantation. Heart failure, again, is very important. For anytime you have a heart failure patient, you like to manage them with the ACE, the ARBs, the ABCDE of heart failure management. It's important that I talk about this here. You can use ACE inhibitors and ARBs, but we tend to use lower doses. Um, these patients tend to be volume dependent, and you want to make sure that if you use an ACE and an ARB because of its impact on the volume and fluid fluctuations, you are using lower doses. I actually prefer to use aldactone rather than lisinopril or other agents for these patients. Loop diuretics are the key. Salt restriction is important. One drug that you should not use at all in patients with amyloid is digoxin and calcium channel blockers. You will see excessive toxicities because of the way these drugs actually bind to patients who have advanced stage cardiac and importantly renal amyloidosis with low albumin levels. So never use digoxin. If you have a patient who's being seen by an old school cardiologist and they still like to use digoxin, please tell them never to use it. I also don't use calcium channel blockers like verapamil and things like that in these patients because of their increased cardiotoxicity risk. Non-selective beta blockers, propranolol, you should not use again because the binding to the heart in patients who have advanced stage disease with low albumin levels. You can still use you can still use metoprolol at lower doses, but non-selective beta blockers, digoxin, and calcium channel blockers should be avoided in these patients with heart failure. Another important point that I want to share, and I really emphasize it when I see patients with AL amyloid and I send it back to the community doctor, is that please do not use 40 milligram of dexamethasone unless you want your patient to go to the ER the same night. If you give 40 milligram or higher dose of dexamethasone with the chemo, that's typical with these therapies, it's a perfect recipe for exacerbation of heart failure, fluid retention, and a visit to the ER. I almost always invariably start with 20, and within one dose, I drop to 10 milligram of dex. And there are times when actually I don't even give them dex because you don't need steroids really and truly with such effective therapy like dara and bortezomib and cytoxin. So lower doses of dex, and if you see any problems with fluid retention, like in the legs and heart failure, cut it out altogether. You don't need it. And then finally, bleeding problems. And if you ever notice easy bruising, easy bleeding, and you're planning to do a cabbage, or for that matter, a kidney biopsy, please make sure you check your coagulation factors, you replace them. Otherwise, your patient will bleed on to death on the table. We've seen this happen with kidney biopsies that you have to check the coagulation profile and do it in a safe manner. So that's all I have. I think we were able to finish in time. I'm happy to take any questions that anyone in the audience may have regarding AL amyloidosis.
Thank you, Dr. Hashmi, for amazing presentation. We have one question in the chat from Dr. Faisal. How does TNT correlate with high sensitivity troponin?
Yes, it's a very good question. So there are different forms of troponin that you can measure. There is troponin T and there is troponin I. Their values, their ranges, their cutoffs are different. In my institution, and I think many institutions in the US, would we use a high sensitive troponin or troponin I. There is actually an online calculator where you can calibrate troponin I with troponin T if you don't have it available at your site. But for the purpose of staging these patients at a time of their diagnosis, you need the troponin T. Although there are conversion um, uh, calculators as well that you can use if you don't have troponin T that you can measure. So I see, Salman, I see your I see the question here, what you mean by that. I have struggled myself. So my side didn't have troponin T, it was a send out, so I would just calibrate it. But at least I would do it once at a time of diagnosis to get the stage. Because the stage depends on NT-proBNP and troponin T. You can alternate the troponin I for the 2014, but again, this can be a challenge.
Thank you. We have one more question from Dr. Thedha. Do you ever use 1.5 milligram per meter square in Elevate or myeloma, or is it 1.3 standard starting dose?
Yeah,
and how
so
do you adjust dose of, sorry.
Yes, sure. So you have a good question, and this comes up all the time, that bortezomib dosing, Cyber D has at least 3 to 4 different iterations of its dosing and schedule. And for the sake of simplicity, when I use Cyber D, I usually give 1.3 milligram meter square on day 1, 8, and 15 on a 28-day cycle. There are schedules and there are dosing where they give it 1.5 milligram meter square day 1, 8, 15 and skip the day 22. They give the 1.3 milligrams meter square on day 1, 8, 15, and 22. So you can see multiple different iterations, but I think there's no randomized trial. There is no randomized trial as compared 1.3 with 1.5. In my own practice, uh, where I'm very used to 1.3, I give 1.3, 1, 8, and 15, and not 1.5. The reason I do that is because I think 1.3 is lower cumulative dose of bortezomib and perhaps a little better for these patients who either have neuropathy to begin with or can develop it, which can be really debilitating for these patients. So that's why I usually start off and keep them at 1.3. And any renal failure patients, you can give bortezomib to anyone with renal failure. I think it's more the liver enzyme abnormality and liver synthetic dysfunction where you have to be careful with the bortezomib. But renal failure patients, you can give them without any problem.
I have a question from Dr. Iman. After the initial treatment, those patients with cardiac light chain amyloid who has achieved remission, how do you follow these patients? Can you have recurrence without changes in myeloma markers?
Yeah, that's a very good question. So, let's say we give dara-VCD to a patient with cardiac amyloid. When they see me, Hassan, then when they see me very first time, I make sure I get an NT-proBNP, a BNP, and a troponin. I give them chemotherapy, light chains with each cycle. I usually do the BNP at least every 2 to 3 months. And once they've finished therapy, I actually follow them with BNP and the troponin every 3 months or so. If they are improving, it is showing me an organ response, which is dependent upon your BNP and NT-proBNP. I may scale it back to every 6 months beyond a few years, but I usually continue to follow them for the rest of their lives with BNP and troponin at each visit, which is usually 3 to 6 months. So that's how you follow the cardiac biomarkers are very sensitive. Troponin is very sensitive in picking if there is any amyloid in there. So that's how I follow them. I do tell all my patients, you will get a heme response within 2 months. By 6 months' time, it may be all gone. Your troponin is going to be elevated. Your BNP is going to be elevated. It will take 2, sometimes maybe 3 years for you to have a response. And not everyone gets a response. So it's very important to set that expectation and follow it over a period of time. Your second question is very important. I think we talk about amyloidosis guidelines. We're working on them right now, and this comes up all the time. What do you do for patients who have organ relapse, but they don't have evidence of light chains? In those cases, I always make sure that if it's a renal patient with a history of renal AL amyloidosis, there's no alternate etiology or cause behind the nephrotic range proteinuria. Let's say the light chains totally normalized and patient was under observation. They came in to see you and they started having more nephrotic range proteinuria and their light chains are slightly elevated. I will rule out all other etiologies, and I would consider sometimes in these patients even a kidney biopsy, repeat one, to see if there is any evidence of amyloid. But it becomes very tricky because even when you look at amyloid in the kidneys, the deposits can remain there. Mass spec can sometimes tell you whether that's still lambda seen in there or not. Because even when you have the deposit, you should not see the mass spec telling you that is AL lambda subtype in there. So even at big academic centers, we struggle with this question. So what I do is that I look for alternate etiologies. I do a biopsy if I have to and see if it's going to inform me of anything. But it can be a tricky question to answer. If you have set up with an academic center, I would strongly recommend send those patients to those sites to have an evaluation.
Dr. Lada, I have another question. Do you do same in DERA VRD as well in myeloma?
I think it's for bortezomib. Yes.
For the
My data RVD, and I'm an MSK, so we have it standardized. Everyone uses the same order set. We give 1.3 milligram meter square a day, 1, 8, 15. Not twice weekly, not 4 weeks in a row. 3 on, 1 off with bortezomib 1.3.
Dr. Faisal has a question for MGUS that we see once a year. What direct questions we should ask them for amyloid? Do we need to do 24-hour urine every year?
Yeah, so usually the MGUS patients that I see, every time I see them once a year as well, I always ask them about any recent ER visits, hospital visits, medication changes or life events, because oftentimes if they have a heart failure or if they have kidney problem, a primary care physician would notify them, right? ER would actually find out fluid retention and things like that. But the question that I ask them always, are they having profound levels of fatigue? Are they losing weight without their intents and it's significant weight loss documented? And if they're having symptoms of anorexia, poor appetite, fatigue, malaise, lethargy, my suspicion gets really high alarm if it's a lambda subtype protein. So IgA lambda, IgG lambda, because 80% of all amyloid is lambda, 20% is kappa. So if it's a lambda one, I actually bring them in. Then I do a 24-hour urine assessment, troponin, BNP. If I still think that there is no explanation for these symptoms, I can't explain it otherwise. I actually would consider a bone marrow and a fat pad.
It's just one question from Dr. Hussain. Disease-free light chain versus kappa lambda ratio. I think that was his question.
Yes. So I think the kappa lambda ratio is important for myeloma at a time of diagnosis. Anything 100 or above is actually characteristic of myeloma defining event. It doesn't have a value when it really comes to AL amyloid. In AL amyloid, the way you determine response, partial response or VGPR for that matter, is based on delta free light chain, as they call it. So you essentially subtract the lambda from the kappa in majority of the patients, and that is what determines what response they have had. Your delta or difference in the lambda and the kappa light chains, if it's less than 40 milligram per liter or 4 milligram per liter, is a very good partial response. So that's, I think, what you are alluding to. So kappa lambda ratio has limited no value. It's really the delta between the involved and uninvolved. And I don't use the word kappa lambda. I usually use involved uninvolved light chain ratio, or involved minus uninvolved for the DFLC.
Thank you so much, Dr. Hashmi.
Thank you, everyone. I hope you enjoyed this. I'm sure this recording or the slides will be available to you for use. I have also shared my email in case you ever have a patient that you need help with. I'm more than happy to help you out. Thank you.